Okay, so before we got interrupted with our lovely fire alarms there, we had talked about what was going on in our profession and the need to add a body of evidence that suggested the importance and the benefits of occupation for people, for our clients. At the time, there was a growing body of evidence for other disciplines like nursing, physical therapy, medicine, all of those things that were showing evidence for the efficacy of those other disciplines. And so we needed a study where we needed a discipline, we added a discipline to add or to show or to highlight the importance and benefits of adding occupation for our clients. Again, sort of using our models of practice to bring occupation back to our identity, back to our core as a profession, and then now adding this other discipline that's really going to help us focus on adding to that body of evidence, that body of knowledge. So I'm hoping that you guys will understand the need for theory, which helps unify our profession. It helps guide what we do, how we evaluate, what interventions we choose to do with our clients in order to best help them. But also, I want you to try and understand where we're at as a profession with our growing body of evidence by looking at the different levels of occupational science. So we've read the different practice dilemmas already, right? And one is very much medical model, and the other one has more occupation-centered, occupation-based. And I think what I was hearing when everybody was sort of discussing them was how you would choose the one with occupation in it. It just seemed more meaningful. So, you know, hopefully you're all on that same page. And if not, maybe throughout the course of the semester, maybe we'll get you to that page. So occupational science, again, it's its own profession. You can major in occupational science. You can get a bachelor's degree in occupational science. I believe you can even get a PhD in occupational science, just really looking at the study of occupation in general. And so again, when we were talking about some of those models of practice, they sort of emerged around in the 80s, right, all the way up to the 2000s, again, in an attempt to unify our profession and bring occupation back to the center of who we are as our identity. During that same time frame, we're like, but we kind of need evidence that shows that occupation is working, to show that occupation is as beneficial to our patients, in which we already knew, but we needed the evidence. And so, you know, changing degree plans to master's degrees, doctor degrees, those kinds of things in OT wasn't necessarily happening or wasn't necessarily helping so much. And so the University of Southern California, Florence Clark, she's still around, but USC was the first to develop a degree plan that highlights occupational science. So again, this emerged around the later 80s. So right around the time when, hey, we have these models of practice, occupation's what we need to go back to, but now we need evidence that shows the benefit of that. So the original vision when developing occupational science was to just provide detail in what engaging in occupations look like. What is a typical engagement in occupation? What does it mean? What does it look like? Because as you know, occupation can be very, very, very complex. How I bathe might be different than how you bathe, might be different than how Florence Clark bathes, right? Everybody does things a little bit differently. We all have our routines, we all have our habits, we all have those sorts of things that impact how we engage in occupation. It's also heavily influenced by culture. It's influenced by environment. It's very, very hard to pin down and to study with really strong evidence, okay? So initially, we just wanted to try and explain, identify, describe what a typical engagement in occupation looks like. This would allow us to bring attention to occupation. It would allow us to provide a unique occupational therapy perspective, highlighting the importance of occupation. So they started adding degree plans, okay, bachelor's degrees in occupational science. They started increasing journals, publications. So there's occupational science journals. There's publications looking at, again, describing different occupations and breaking them down on that scientific level. There's also national and international occupational science organizations out there. So the National Occupational Science, I can't remember if it's society or it's very similar to AOTA, but it focuses more on occupational science. And again, the purpose of that, when you're looking at journals, they're producing large amounts of peer-reviewed articles, right? And so that becomes our body of evidence. And so by having occupational science, by having international organizations, national organizations, journal articles, it's providing that data-driven research to add to our body of knowledge that shows just the importance and significance of occupation. So OTs like to borrow things from other disciplines, right? And so we have 4 different levels of occupational science. Now, I purposely left of an occupational lowercase because when you're looking at nursing research, science research, those kinds of things, the 4 levels of science is the same, okay? It's just level 1, that very basic level is descriptive, level 2 is relational, level 3 is predictive, and level 4 is prescriptive. So all of these different sciences, disciplines that are really heavy in science do have 4 different levels. So in occupational therapy and in occupational science, we also want to have these 4 levels of our science, which is occupational science. So they can be viewed as hierarchical, meaning that level 1, descriptive, is just very, very basic. Okay, it's describing, in our case, it's describing those occupations. Okay, what are they? Little bit stronger level of evidence, level 2 would be relational. What builds on that and is a stronger yet level is predictive. And then the ultimate level of science, the highest level, is going to be more prescriptive. And so those are your clinical trials, you know, the randomized controlled clinical trials, those sorts of things that are trying to really highlight specific interventions, specific treatments that are beneficial. So some disciplines are heavier in one level. And so biology is going to be really, really heavy and descriptive, or your level 1 type of science, where they're describing things, right? They're describing what is occurring in a muscle fiber. What is the function of this muscle? What makes up this cell, right? It's just describing those key concepts of whatever it is that they're trying to study. Now, the discipline of medicine is very heavy with prescriptive, right? So prescriptive is that highest level, And so there's randomized controlled trials on one drug versus another drug, right? Which one has less side effects, or what are those side effects? Does taking Zithromax, a Z-Pak, for 10 days reduce symptoms of a bacterial respiratory infection? Okay, and so getting huge sample size, administering the medication, right? And then determining, okay, is it effective in the treatment of that upper respiratory infection? If it is, great. Then doctors read that and they're like, okay, so when my patient comes in with these symptoms, I'm going to prescribe this medication and it's going to get them better. There's a chance that it's going to get them better. Disciplines can borrow from other disciplines too. And so it's not uncommon for OT to look at maybe journals from neuroscience, maybe journals from physical therapy, maybe journals from nursing, okay? All of those other articles or research or scientific study can still benefit us as OTs, and we're hoping that with the emergence of occupational science, that will have some other positive effect on other disciplines also. And so you can't really see it. It's in white. It says, what does OT do? And that's what we're going to focus on, or I'm going to show you where we're at in our profession with occupational science within these 4 different levels, and try and get you a better understanding of what it looks like, what they look like for us. So level 1 is descriptive occupational science. And so again, it's just a need to explore a wide variety of occupations as experienced by everyday people in their everyday contexts. This could be people with or without disabilities. It's just, what is occupation? We're trying to describe what occupation is. We're trying to describe what it is. We're trying to describe that everyday lived experience by certain people who engage in that occupation. What are the contexts of an occupation? So we're really just trying to define different areas of occupation. If we understand the effect occupation has on people, we understand what those people are experiencing when they're engaging in occupation, we can better use occupation to make people better, right? Well, we have to understand what occupation is. And so Florence Clark, again, sort of the person who really coined occupational science, there's a quote, "Occupational science is to occupational therapists what anatomy and physiology are to medicine." And so when you think about a doctor needing to know the anatomy, physiology of the human body, occupational therapists need to have that level of understanding about occupation. Level 1 is that basic level. It only provides foundational level knowledge, okay? Identifies, describes factors, maybe explains the dynamics of occupation, what those dynamics are. And I don't mean to minimize level 1, because it's extremely necessary to have those basic descriptive levels before we can start building upon it with stronger levels of evidence. So we need a lot of descriptive occupational science. We need a lot of level 1 studies. So when we start identifying what those concepts are of occupation, then we can take it to step 2. Oh gosh, excuse me. So some level 1 examples that are in the literature, okay? Mothering occupations. So what is mothering occupation? What are the contexts? What are the situations? What is mothering occupations? And so in some of the studies revolving around mothering occupations, you see concepts such as birthing, the birthing process, right? Giving birth. Feeding the baby, right? Eating, sleeping, comforting, managing a home, So in the literature on this level 1 level, or on these level 1 examples, these level 1 studies that describe mothering occupations, they're identifying that mothering occupations are made up of birthing. They're made up of feeding, eating, sleeping, comforting, and managing a home. Okay, so they've, with their level 1 research, they've been able to identify those concepts, and that's what's occurring when we're talking about mothering occupations. Caregiving. What is caregiving? Okay, so we've looked at the occupation of caregiving, and it could include caring for elderly in the home. It could be interacting with other healthcare professionals. And so when we're researching what caregiving entails, these are some of the topics that explain what caregiving as an occupation is. Routine. You'll hear routine brought up a lot in our profession, how important routines are. And so some of the level 1 examples are just exploring morning routines in typical people. What is a morning routine? Well, a morning routine is a sequence of actions. So what are those actions that typical people engage in the mornings? And you can guess: bathing, dressing, eating, okay, some of those other things. And so based on, and it may seem like common sense, but when there's nothing in the literature that specifically identifies it, then we're not using evidence, and we want to use evidence in our profession. Some gaps that the authors have identified in level 1 literature, which I thought was interesting, was what are specific male occupations? And so, you know, we have mothering occupations, fathering occupations hasn't necessarily been explored, or what do men typically do for their typical occupations? Another area that's been identified as a need with level 1 studies is looking at and describing more about sleep and rest as an occupation. What does it all entail? What are the concepts? Okay, and so they're saying, okay, sleep and rest, we're seeing some of that in our models of practice, or we're seeing it in our OT practice framework, but there isn't a lot of level 1 studies that even talk about what that all should entail. So we need to have that basic level 1 studies, that basic level 1 evidence that tells us what something is, right? And now if we know what something is, now we can relate it to something. Okay, so level 2 is going to be relational occupational science. And so it takes things from level 1, but it allows us to apply those things to practice. So in relational occupational science, it might help us identify relationships among concepts. So what is the relationship of daily activities of children with cerebral palsy compared to a typical child or a neurotypical child? Okay, and so this level has great potential for OT to relate occupation to specific populations: people with disabilities, people with different identities, people with different cultures. Okay, so the possibilities here are just completely endless. Okay, we could look at occupations with those who have had CVAs or strokes. We could look at how retired people and their identity change through the use of occupation over time. Okay, so gaps with level 2, we're noticing when we start covering the topic of occupational justice. Just in a nutshell, occupational justice is concepts that everybody has the right to engage in meaningful occupation. But there's barriers sometimes that prevent people from engaging in meaningful occupation. And that's an injustice. Okay, and so we know that some people can engage in meaningful occupation okay? We don't necessarily know, we don't have in the evidence how that impacts their overall health and wellness. So a gap in the literature is, how do factors that inhibit people from engaging in occupation affect overall health? Okay, so we're looking at what is that relationship from those who can't engage in occupation, and what is the effect on that for their health? Looking at what is the relationship of occupation and culture? Okay, so I've shared with you guys already about my experience with, you know what, here's how I bathe in the shower. I'm going to a different culture. I just assume that that's how they bathe because that's how I bathe. But culturally, that's not the case. And so how does culture impact occupational choice of people, right? How does culture impact how people engage in occupation? How is occupation and health, or how is occupation related to health? How is occupation related to quality of life? How is occupation related to life satisfaction? And so we need stronger evidence that justifies the use of occupation to enhance one's health, to enhance quality of life, to enhance life satisfaction. We also have, or there's also a gap in the literature. Again, I talked a little bit about what is male occupations, or occupations that men are seeking, that they want to engage in. And with level 2, it's what is the male gender identity? How is that related to occupation? So again, there could be a whole study that could be more heavily studied, is male gender identity relating to their occupation, their occupational choice, their occupational participation. So really your level 2 relational occupational sciences, we're taking concepts from level 1, what is occupation, okay? And we're applying that maybe to specific populations. What's the relationship of occupation to culture, occupation to somebody with a disability? If we know and we can identify what that relationship is from somebody with a disability and how they engage in occupation, and we can describe that, and we know what that relationship is, then maybe we can predict, maybe we can use those levels of evidence then to build on each other in order to predict perhaps an outcome, okay? So level 3 provides research into broad patterns of occupation. And again, it's an attempt to predict outcomes. So if I know somebody with a CVA, engages in the occupation of their morning routine, so bathing, dressing, eating, and I know how their CVA has affected their occupational performance, okay, then maybe I could find out if we use morning routines of grooming, hygiene, dressing, bathing, eating for individuals with stroke, that could impact their overall quality of life. So with predictive occupational science, we're trying to predict by saying, hey, if we do this treatment with this clientele group, it's going to improve upon this. It's going to predict an outcome of some sort, whether it be better quality of life, whether it be greater levels of independence, okay? Unfortunately, at level 3, in order to make these predictions, it requires really, really, really large sample sizes, okay? It involves using quantitative research measures, so surveys, quantitative tools, very specific measurements that we can use and we can track over time. We can plug into computer matrices like SPSS and those sorts of things, run multiple regression statistics to try and improve or to try and see if there's a predictive value in using some of those quantitative tools. So it would be great if we could attempt to predict occupations across the lifespan, considering some of those social conditions. So what are occupations completed by individuals with lower socioeconomic status, for example? Okay. And so can we predict, looking at lower socioeconomic status, could we predict if we look at that aspect, would we be able to tell what those meaningful occupations are for people with lower socioeconomic status? Okay. Now, you can probably relate, or you can probably already understand that we have the fewest examples in our field of this level 3, okay, of predictive occupational science. We have the fewest examples in our field. An example in our field might be something like typical development of a child, and where that child is at developmentally. Can it predict what they would play with, or could it predict their factors of play? We know play is an occupation of childhood, and so if we know the child is chronologically age 4, would we be able to predict what a 4-year-old would be able to do in play? Okay. We do have some of those studies already looking at theories of play and those sorts of things. We do have some of those. But we're really trying to develop standardized, norm-referenced assessment tools, right, that help us acquire a certain score. And if we know what that score is, we can interpret it to predict some level of functioning. Okay, and so I know it's kind of hard to grasp, but basically, when we talk about standardized, norm-referenced assessment tools, in our other course in OT evaluation, some of those assessment tools, and again, we're borrowing a lot of these assessment tools from other disciplines, but they're used in an attempt to sort of predict how they'll function. Now, a really good example that I can think of off the top of my head is the Berg balance scale or the Tinetti balance test. Heavily used in physical therapy. I do know occupational therapists who have used them. They're standardized assessments, standardized tests that you administer to a patient, to a client to test their balance. They get a balance score. Okay, based on that score, you could predict their level of fall risk. So if they get a really low score when administering one of those tests, right, you would say they're at high risk for falling. And so again, using that sort of standardized assessment tool can help us predict and get that score, can help us predict how likely that patient would be to fall and injure themselves, okay, which can be a pretty useful tool. So our gaps at this level really are looking at occupational patterns across development, across the lifespan, okay, and more specific occupational assessment tools that can predict outcomes. So like I said, the Tinetti, the Berg balance are heavy in the physical therapy field. We do sometimes use those. They measure balance. Okay, well, balance isn't necessarily occupation, right? Does balance impact occupation? Absolutely. Yes, it does. And so that's where some OTs might, okay, you're having falls in your room, you're in a skilled nursing facility, you're having falls in your room, you're having falls getting to and from the bathroom, which impacts your in-room mobility, which impacts your ability to complete toileting safely and independently. Let's do a deeper analysis of that, analyze it, occupational or analysis of occupational performance. Balance is a huge component of that. So let's do one of these standardized assessments and get a balance score. Okay, based on that balance score, you're at a high level of risk for falling and injuring yourself, meaning your balance is what is impacting your ability to transfer safely and to move about your room safely. So then our interventions might be to work on in-room mobility, might work on toilet transfers, might work on safety awareness, those kinds of things. And I would hope we would cross-refer to PT to look at more strength, also balance, and some of those kinds of things as well, okay? So again, we want more occupation-based assessments and not always borrow from other people. Level 4 is prescriptive occupational science. And so this is research put into occupations used as interventions. Okay, so we can prescribe an occupation, we can prescribe a program to somebody, and we would know that they're going to get better based on the prescription, right? Sometimes we refer to it as applied research, so we're looking at the effect of an intervention. So you might see, okay, in level 1 research, here's the occupation. We're looking at the occupation of bathing. What does it all entail? It could include sitting in the bottom of a bathtub. It could include showering. It could include standing at the sink using a washcloth. Okay, so now we understand what the occupation of bathing is. Number 2, relational. Okay, we're looking at what is the relationship of individuals who've had a stroke and their ability to bathe. Okay, and so in those studies, we might find that people who have just suffered a stroke are more likely to be successful with sponge bathing, sitting at the sink, using a washcloth, right? Using one hand to wash their face, and that's their highest level of success for self-bathing, is doing it that way. So we understand that relationship. Level 3 might be to predict. Okay, so, and I don't even know, this may not even exist. I'm making this up. Okay, so after 1 week of post-stroke, right, they're going to gain increased range of motion so they can start actually washing their face with both hands at the sink. Okay, and so we know that after a certain amount of time goes by, the likelihood that that person with a stroke might gain function of their affected arm or extremity. Okay, so we're looking at those level 3 studies. And again, we don't have a lot of those in our profession, but that would be an example is, would time be a predictive factor in stroke recovery? Okay, I'm not sure. Level 4 studies, then if we have level 1, level 2, level 3 studies, then our level 4 studies become more scientifically sound and more scientifically grounded, okay? Because if I'm looking at the occupation of bathing for somebody who's had a stroke, okay, and doing it this way is proven to be most effective, now I'm going to be doing something like applied research, where I'm going to say, okay, now I have all these people who've had a stroke. I'm going to implement this type of bathing with 5 of them, or 500 of them, and see if they increase levels of independence, see if they increase range of motion, see if they increase quality of life. These other 500 people who've had a stroke, I'm not going to do that. I'm going to do more classic range of motion, more biomechanical approaches, less occupation-based focus, those sorts of things, okay? Then I would compare the 2 populations and say, after those interventions have been completed, and I would follow up with all of those measurements and see, were there any improvements? What were those improvements in? So then a study like that, I would say, wow, after 5 weeks of having people with stroke, a certain type of stroke, take their unaffected arm, put a washcloth in their hand, put it on top of their affected arm, and use their unaffected side to integrate their affected side to wash their face. And we did that for 5 weeks. And after that 5 weeks, they've increased range of motion, they've increased strength, they've increased levels of independence, as compared to more of the biomechanical approach where you're just stacking cones, you're doing those kinds of things, right? So then when I would read that study, I would say, you know what? I'm going to do that with my clients who have had strokes. I'm going to implement face wash, bilateral hand face washing with all of my patients who've had strokes, and after 5 weeks, I should see them get better. Okay, that's what prescriptive is. So that's why we need level 1, level 2, level 3 level studies to get to level 4. And again, we don't have a lot of these either. Our profession sort of peters out after level 3. We're getting better, we're getting better. Again, Eleanor Clark-Slagle, the big, head honcho of occupational science, did this famous study, a elderly study. It was a huge, large-scale study looking at the effectiveness of a very specific OT intervention for community living, elderly populations. Okay, and so the elderly study conducted by Florence Clark and her team of colleagues looked at, we want to help the elderly population continue to live and prosper in their community home. Okay, so we're going to get a group of elderly people, people that don't have a lot of conditions, if you will, and we're going to do this group. We're going to go over safe cooking. We're going to go over falls. We're going to go over maintaining strength. We're going to go over maintaining balance. Okay, now we're going to follow up with them over time, making sure that they're still doing this activity, making sure they're still doing this intervention. And they tracked them over time, and they found that they were less likely to have falls, that they increased their report of quality of life. And so really, really, really great example. And I hope you guys actually read that particular study at some point. I think Dr. Anderson Dr. Cindy Anderson is going to bring it in one of her courses. And so very, very popular study. Again, we don't have a lot of prescriptive research, and this is one that we do have. There is an assessment tool out there also that uses prescriptive, or it's more prescriptive. It's called the test of grocery shopping skills. And so really they're using a familiar environment. So whatever grocery store that they're used to shopping in, which would functionally assess that occupation and help predict perhaps that their cognitive functioning or cognitive impairments. Okay, and so it's a more of a specific grocery shopping certainly is an occupation, right? And level 3, we identify we need more occupation-based assessment tools specifically related to occupation. So here is an occupation assessment meant to measure grocery shopping skills. And based on that test, based on having the client go through and do this grocery shopping skill assessment, we can predict what their cognitive impairments are. Okay, so it's really quite cool. Again, we have gaps. We could always use more occupation-based assessments that help us identify goals and interventions. Okay, we need more of that. Oh, didn't mean to click on that. We need a lot more of that. We need a lot more of that. A lot more of that. We also need a lot of prescriptive types of interventions. We need more applied research articles out there that justify and that share very specific interventions that would help people. When we talk about occupational justice and occupational injustice, Okay, we know that people, that there are some populations of people that don't engage in occupations. So for instance, individuals who identify as transgender have been shown not to do health maintenance, not to go to their medical appointments for follow-up. Okay, so we know that exists. We know that some of the qualitative literature that's out there talks about how uncomfortable they feel going to a medical provider. How how judged they feel when they go to a medical provider and they don't feel like the medical provider is really hearing them and helping them, or they feel like the medical provider isn't qualified to answer some of their medical concerns or questions. So then they don't go, right? Well, if they don't go, if they don't get the treatment, they're at a much higher, or just not treatment, but like they don't go for their routine physicals, those sorts of things. They're more likely to have issues with, I gotta think back into the literature. They're more likely to have issues with complications with illnesses, right? Complications with, they're not getting a lot of education on how to live a more healthy lifestyle, if you will. And so they're more susceptible to smoking. They're more susceptible to substance abuse. And so again, there's relational studies in occupational justice, in occupational injustice for that matter, looking at specific populations of people. And now we're able to relate it to unhealthy outcomes, and we're able to relate it to how and why, but there's no applied research saying how we can improve that occupational participation with certain populations, okay? And so we're gonna talk a lot about that at the very end of the semester. We'll talk about occupational justice, and I'm going to, and our final assignment is going to be to propose a use of a model of practice, because they're broad enough, they can be applied to any population. They should be able to be applied to any population. But what can we use from that model to guide us in treating a vulnerable population, to find appropriate interventions to help? Okay, and I think we can use those models as a framework in order to do that. And so just think about, and this is taken right off of one of our assignments on one of our papers. Okay, and so I want you to think about that. The paper's not due for a while, right? It's not due for quite a while, but we've talked a lot about the history of our profession and how we have models of practice in order to unify our profession, right? Because we were all siloed, and that was creating confusion among us as a profession, but it also was creating a lot of confusion with those with whom we work. So our colleagues, right? Our non-OT colleagues, it was causing confusion with them, and it was causing a lot of confusion with our clients as well, okay? So why did theory originate in our profession, and how has it evolved? And so, you know, we sort of jumped on the back of other disciplines, looking at the biomechanical frame of reference, right? On, okay, if we do range of motion, it's going to increase function, okay? And so we were locked into that at that particular setting, right? And then we're like, oh, am I doing anything different than PT? Not really. Okay, well, why are they going to choose me over PT? Why do they need both of us? Do they need both of us? Okay, well, yes, they do. They do need both of us. And so we knew that. So we needed to get more theory, right? We needed to get our own theory to give us a different, unique perspective than some of the other therapies, some of the other disciplines that are out there. So that's where theory came into play. Now, theory is like, okay, well, we think there's a connection between the person, there's a connection between the environment, there's a connection between the occupation. If we change this part of the person, it's going to change their performance and their occupation. Prove it. Prove it. Okay. We want to be evidence-based. We want to pull from that body of evidence in our field. There are no studies. So we created occupational science so that we would be looking at and really studying occupation scientifically, like our other disciplines. Like nursing is very scientific, right? Doctors are very scientific. PTs are very scientific, right? And so we're really looking at occupation scientifically so we can build on that body of evidence that shows how and in what ways and just how effective it is to make change with the person to increase their occupational participation. And then what that does. Does it increase wellness? Does it increase independence? Does it increase health? So in your own words then, describe the identity crisis of OT and what solutions has the profession made to remediate this crisis? And so again, with the crisis being, what do you do as an OT? I don't do that. I look at activity. Well, I look at occupation because I'm trying to get this veteran to be able to get a future job when he leaves here. Oh, that's interesting. I just look at play because I'm a pediatric therapist. Oh, that's interesting. I only look at education because I'm in the schools. And so you're not really a real OT then because you don't work in the hospital, you work somewhere else. And then, oh, well, yes, I am, I think, but I don't remember covering that in OT school. Did we have the same training? Well, I don't know. Did we? I don't know. And so that created a lot of crisis for us, right? And so again, AOTA was like, we need to get on the same page, people, okay? So we're gonna create a document and we're gonna use this document so that everybody in the profession is using the same terms appropriately. But we don't want to offend the peds therapist who says purposeful activity. We don't want to offend the rehab OT who uses task. We don't want to. So what they ended up doing with practice frameworks, and before practice framework, it was uniform terminologies. They defined them all. Okay, and then that really didn't help a whole lot because it didn't unify, it just differentiated. And then these models of practice came out and said, well, we're going to define it then, and we're going to, with a theory, we're going to try and make some connections between the concept of occupation, person, and occupation, person, and environment. We're going to try and make some of those connections and define what some of those are, and try and make some statements about how they impact each other. And so the documents that AOTA has come out with has evolved and changed over time. And you'll notice that it picks up on some of the terminology that we'll be using with our occupation-based models. And so just know historically, this was all sort of occurring at the same time, right? That AOTA was putting out professional documents with definitions on them, right, to try and unify our profession. Models of practice were being published and created. And then as that AOTA document was being updated along the way, right, it was like, okay, we're gonna pull from this model, we're gonna pull from this model, we're gonna pull from this model. And so you'll notice some of that, you'll get a feel for some of that when you read the OT practice framework and when we look at some of the different models, okay? So has that been helped? Or has that helped our profession, do you think? How successful have these solutions been, okay? Is our identity crisis fixed now? And if not, if you don't think so, what further solutions would you propose? And so this is where I challenge students. AOTA has come out with a professional document also that has sort of said, you guys got to start using occupation again. Like, you can't lose sight of occupation, right? Because there's therapists out there who are still very biomechanically trained. And they don't look at the broader picture because they're pigeonholed in their setting, okay? So AOTA is trying to like whip them into shape. The other hope, you guys, is when you guys go out on field work, when you guys get into the profession, that you help further bring occupation back to where it needs to be. You help bring it back to our identity, because that's what we need. Okay, and so you are agents of change. You are agents of hope to bring us back and bring us full circle back to who we are and who we intend to be as occupational therapists. So you, all of you, are our future solution to continue working on fixing our identity crisis. No small feat, no small feat. So don't lose sight of these practice models we're going to be covering, because they will help you define and hopefully understand what occupation is. And so that's what I have. I will get this posted as soon as I can upload it to YouTube. Thank you so much for your patience, you guys. What a mess this morning with the fire drills. If you have any questions, reach out to me, and I will be sure to help out in any way I can. Thank you.